Hey, everybody. Welcome to another Sunday morning conversation. Today, my guest is Jai Carmichael. He's working on his PhD in neuropsychology at Monash University down in Melbourne, Australia. Thanks for tuning in, everybody. I hope you enjoy.
Hi, Eric.
How are you?
Good. How are you?
Another day in the life. Forgot my wallet somewhere, so I got to go pick that up after this.
Oh, no. What time is it there?
6. So
6. Okay.
They'll still be open by the time we finish. So
Okay, no worries. Well, yeah, I hope 6 o'clock's an okay time. I think we're complete opposite time zones. So
it's fine. You've got to keep in mind that with the TBI, I'm one of those people who has really cockeyed sleep. So sometimes I'll be up for a long time, and this is probably one of those times. So I would have been fine whenever.
Okay, no worries. Well, thanks for reaching out. Keen to have a chat with you.
Yeah. I had been reading through, you don't have a lot of research done because I guess that's not what the type you're going to be into. But I only saw like 4 different things on Google Scholar. But when I read your bio on, was it Monash University? Is that how you say it?
Yep, that's right.
Yeah, you've got like a litany of things on here. Anywhere from, it starts at, you look at neuropsychological syndromes all the way down to mentoring. So could you explain a little bit more about yourself and what I would find on your bio?
Yeah, sure. I'm not even sure what's on my bio, so if I don't cover something, you'll have to let me know. But essentially, Eric, I'm a PhD candidate at Monash University. And it's a clinical PhD, so that means that I do training to be a clinician, specifically a neuropsychologist. But I also do research on top of that as a part of my PhD. So on the research front, I guess what you'll have seen that's been published is I've done some research looking at behavior change after an acquired brain injury, be that a TBI or another type of acquired brain injury. And I've also looked into the genetic factors that might influence outcome after a traumatic brain injury. My PhD research, though, is more so focused around emotional difficulties after traumatic brain injury. So because I'm still doing my PhD, we're still in the process of collecting that data. So nothing's been published on that yet, but that's probably my primary research focus at the moment, and happy to chat with you more about that. And then, on top of doing my own research, I supervise some honors level students, so students doing their undergraduate research in psychology to conduct their own research.
Did you need to have a master's before you went into this? Do you have to have the bachelor's, the master's, and then the PhD?
No, actually. So the way it works, and I'm not sure if it's, I think it might even be similar over in the States, is that at least in psychology, you have to do an honors year. So it's like the 4th year of a bachelor's degree, and that's your first time doing some research. So you have to do that, but then you can go straight into a PhD. And I think part of the reason why you can do that is it's actually sort of the master's and PhD combined. So you do, in the first 2 years of the PhD, do clinical training, you do placements, but on top of that, you're doing the research that comes along with a PhD.
So 4 years total.
So it's 3.5 years for the PhD if you finish on time. So if everything goes, according to plan, I'll finish up August of next year. And then the bachelor's that you do before that is 4 years.
To go back to how you work with emotion control with people with either TBIs or acquired brain injuries, do you happen to find that the overwhelming emotional response that we have is anger?
Yeah, so I guess or at least when I think about sort of mental health and brain injury, I guess the first thing that comes to mind for a lot of people are things like depression and anxiety. We might call those affective disorders, or, high levels of experiencing negative mood. So on that front, those are pretty common problems. And then I guess more what you're getting at, people call these different things, but sort of more behavioral kind of stuff, or difficulties with regulating your emotions. That's where sort of the anger can come into play. And yeah, I've interacted with a fair few people who've had acquired brain injuries through research or clinical practice. And I guess the two most common complaints, anecdotally, that I hear about are one, fatigue, and then two, people call this different things, but being more irritable or having a shorter temper or getting frustrated more easily. So yes, sort of see that a lot and hear people noticing that they're getting angry more easily or stressed out more easily or overwhelmed more easily.
One of the main precursors to that, at least for me, is confusion. Confusion makes me angry, and then there's an outburst like that. So I don't know if you've seen that before.
Yeah, so probably different for everyone, but it's actually reading this treatment manual actually just the other day about anger and anger self-management after TBI, and they have a cool way of explaining it. They say that there are brain reasons for being angry after a brain injury, and then there can be lifestyle reasons for being angry after a brain injury. And so I guess what you were just talking about there, Eric, would be a brain reason. So you might get confused more easily following the brain injury. This is, potentially been injury to parts of the brain that might help you process information, plan, organize, that kind of stuff. And yeah, when we get confused, when we're confronted with something stressful, and maybe we feel like we can't handle it as well as we'd like to, that could result in feelings of anger. So that might be a brain reason. But then there are also, I guess, lifestyle reasons. So people can be angry at their situation. They've had a brain injury, they've got these symptoms now, it's getting in the way of them getting back to things that matter to them. And, understandably, that's also really frustrating. So, and I think, for different people, it might be a combination of those things.
Yeah, I can actually see, well, I don't know if it's a combination, but with those two things listed, I do experience those at separate times because I'm a triathlete, and it does bother me a lot when I can't compete at the level that I used to.
Mm-hmm. Just for context, and apologies if you did mention this to me, a month or so ago, when we were messaging on Twitter. But when was your brain injury?
October 5th, 2017.
Okay, so
4.5 years ago.
4.5 years ago. Yeah. Still kind of recent, I suppose. I mean, for me, we do research with people, all the way from a few months just after their injury to over 30 years on. So we sort of see the full spectrum.
4.5 years feels like a long time, but it's went pretty fast. Which I don't know if that's normal or not for time to really go that fast, especially when you can no longer work. And it's like, okay, so I don't really have anything to, other than I do this for myself, but I don't have anything else other than this going on. And just the time seems to go fast, and boom, 4.5 years.
Yeah, I'm not sure why that might be. I mean, it sounds like you keep busy with some things, right? You're doing this, you're still doing, you're a triathlete, you're still competing, and incredible.
Not as fast as I used to be, but yeah, I still do it.
Yeah, I guess it's not, well, not to put words in your mouth, but I guess maybe it's not just about the winning, but you just enjoy doing that sort of physical activity.
Oh man, I wasn't winning. I was decent, good to decent, but I wasn't winning anything.
Sure. Yeah, but I guess it sort of still fulfills that purpose for you in some way.
It does, but it doesn't quite. When you're fast and you get slower, it's a mental drain on you. It's one of those things where you don't know if it's just because of your circumstances, your mental health, just father time. You never know exactly what exactly is going to happen, at least when you get older.
Yeah, sort of hear similar things from some of the people we work with as well. Is sometimes it's actually kind of hard to pin down what's causing the difficulties. Often, it ends up being some sort of complicated combination of a few different things. But what's the brain injury versus what's age versus what were difficulties maybe I already had. It all starts to get a little bit jumbled up for people.
going back to the depression and how you work on that. Are you familiar with ketamine therapy to treat depression?
Yeah, look, loosely, not something I'm very familiar with. I know one chap that I've done research with over here with a TBI who had pretty significant depression after his TBI, and he was getting ketamine infusions. And just from speaking with him, he thought that was really helpful for his depression. But other than that, my knowledge is pretty limited. I certainly think we need more treatments for depression in people with and without brain injuries.
I was going to say, I actually did the ketamine therapy here in Atlanta.
And how was that?
Well, it was everything the research had described it to be. I waited 7 months before I actually did it. Like, I had first heard it on NPR. I don't know what the Australian equivalent to, but it's like public government radio, where they're a nonprofit organization. Anyway, it's kind of like politically neutral. So I heard it on one of their science podcasts. And I was intrigued because what the guy was saying is it works relatively fast. After the first session, you actually do feel it, right? And there's 6 infusions you have to go through. I don't remember what the dosage was. But after the 6th one, it works. By the end of the month, you feel great again. And I didn't know if it specifically had to do with my brain injuries, depression, but it worked pretty well.
And what was the process for getting that sort of a treatment organized over in the States? How like, if one wanted to trial ketamine therapy for their depression, what does that process look like?
Well, first of all, we have the health insurance system here. I know you have like some kind of single payer or government healthcare there, right? In Australia?
Yeah, we've got something called Medicare, and then there's private health insurance as well, obviously.
All right. So all we have is really we have that too, but you can't really get Medicare unless you're old or disabled.
I see.
Yeah. And so there's really not a lot of options there because you have to basically your healthcare is tied to your employment. And everybody's got specific doctors that you can or can't see. Well, ketamine therapy is expensive and it's not covered by insurance. So if the guy, you go through an interview with the clinical psychologist, because he was at Emory University here in Atlanta before he started his practice here. You go through an interview with him, whether he thinks you're a qualified candidate for this or not, because depression could not, he may think there's other options still before this, because it's like the last resort. You're in that deep and dark of a hole where it's like there's nothing else that's going to work. So went through an interview process with him, and then we started doing the treatments. And after 3 weeks, I was done, because you go twice a week, 6 times.
I see. And so was that like a research study or just a clinical service?
Clinical service, and it was off the books treatment for it, because it had been our Federal Drug Administration, FDA. It hadn't been approved by that yet, but by the time I finished, it actually did get FDA approved for the nasal sprays.
Right. Yeah. Interesting. So what had you tried anything? I mean, probably you had. Had you tried anything for your depression prior to the ketamine treatment?
Yeah, there was Wellbutrin. There was something else. Might have been another thing, but none of them worked. The Wellbutrin gave me suicidal thoughts.
Yeah, it's almost a cruel irony that sometimes some of the medications we might give people for their mental health difficulties, the side effects can be some of the symptoms of the mental health difficulty that they're trying to treat. In my sense is it's a little bit unpredictable as well. Everyone responds a bit differently.
Yeah, but it definitely worked as advertised. And I don't know how big of an impact it had on at least my brain in the process of recovering. I mean, I'd like to think there was some impact, but I don't know if I could ever figure out how big or what exactly it changed. Like if it healed anything with me, or if the depression by being gone somehow improved other areas of my brain. I don't know how I would figure that out though.
I don't know either, unfortunately. So, sorry, I'm half asking you questions now.
That's okay.
Sort of flipping the role, and I'm just curious. I don't get a chance to speak with many people who've tried ketamine for their depression.
Go ahead, ask any questions you want.
You were saying like the effect was quite rapid. You were sort of seeing quite quick improvements. Was that maintained over time? So you sort of stopped the ketamine treatment, and
Yeah,
then going forward, your depression was better
yeah,
for.
yeah.
Oh,
It
yeah.
literally works that fast. After the first session, I walked out of his office. It was like either February or March of a couple years ago. So it was dark and gloomy, or that's our winter, your summer.
Yeah,
um,
yeah,
so it was dark and kind of gloomy, gray, but it was also just about to be spring, right? And when I actually noticed the birds chirping, and things didn't seem so gray, it
yeah.
wasn't so dull. It was a little bit more crisp and vivid. And that was just after the first time. And my ex fiance did not believe me. I'm like, no, I literally, everything seemed a little bit more sharper in my life when I walked out. And that was after the
Mm.
first one, and it just built. And by the end, I felt like a new man. It was completely different.
That's incredible. I'm so glad you had that kind of a response to the treatment. Do you have a sense of if other people respond in a similar way, or is it different for other people?
Um, from everything I read before I did it, yeah, it's basically the same kind of response to it.
Right. I mean, as I said earlier, I think we need more treatment options for people. For depression, with or without a brain injury, doesn't sort of matter which group of people you look at. What the evidence tells us is that some of our first line treatments for depression only work for so many people. They don't work for everyone. So it's not enough just to have those, couple frontline options. We do need to be looking at more options for people. So I'm glad that that option was available to you and you found something that worked.
Yeah, it definitely was. I don't. It was a godsend. I mean, I'm not really a religious man. I was like, wow, this is fantastic. I can't believe this worked. Because you're kind of skeptical, and then when you use like, except that there's so much literature out about it now that's like, well, then it must be true, and it was. So,
Hmm.
so what is something that you're looking forward to doing research or working with? What do you want to accomplish next with TBI patients?
Yeah, good question. Big question. Look, for me, it would come back to my PhD research. In terms of what I'm looking forward to, we've nearly finished collecting data for my PhD, which means I'll be starting to analyze that data. So to give you a little bit of context to what we are doing in my PhD, is we're trying to come up with a new way of understanding, assessing, and hopefully eventually treating mental health difficulties after a traumatic brain injury. And so the general sort of approach is called a transdiagnostic approach. And it's called transdiagnostic because the way that it tries to look at mental health difficulties is in such a way that it sort of transcends traditional diagnostic boundaries. So if you think about the sort of diagnoses that everyone's quite familiar with when they think about mental health difficulties, they think about things like depression, PTSD, OCD, generalized anxiety disorder, etc. But there are some limitations with that kind of an approach that we've now been using for many, many, many decades. One being that these aren't actually nice, neat little boxes like we might assume. So, for instance, in the Diagnostic and Statistical Manual of Mental Disorders, or the DSM, which is often what is used, including in America, to diagnose mental health conditions, things like sleep difficulties or irritability or concentration difficulties, they pop up in a whole bunch of different diagnoses. So you can have one symptom and tick a box for a whole bunch of different diagnoses, potentially. And one of the consequences of that is that we see that people don't fit neatly into one box. They might have multiple mental health conditions or be, given multiple labels. So after a traumatic brain injury, for instance, it's up to 77% of people who meet the diagnostic criteria for depression will also, on top of that, have an anxiety disorder. So there's big overlap between these supposedly discrete categories. And then the other issue is that within a single category, there can be a lot of variability. So what we mean by that is two people could be given the same label of depression, but they actually have very different symptoms. And that's just because of the way the DSM is set out. So in the DSM, if you want to give someone, maybe not want, but if you're thinking about giving someone a diagnosis of depression, there's a list of 9 symptoms and you only need 5 of them. And that results in many different combinations of very different symptoms that can result in the same label, and therefore people might treat 2 people with different problems, try to treat them in the same way, and it might work for one person and not work for the other. So we think there are some problems with a diagnostic approach, and in my PhD, we are trying to do things differently and see how that plays out in a group of people who've had a traumatic brain injury.
What are the different kinds of data that you had to collect to for your PhD dissertation?
Mm-hmm. So with a transdiagnostic approach, you have to collect a lot of symptom level data. The reason you have to do that, if we wanted to take a more traditional approach, we might say, well, depression is this one unique thing that's different from other mental health difficulties, and it's only got these 9 symptoms. So we're going to ask all of our participants, we're going to give them 9 items or ask them about 9 symptoms, and that would take 10 minutes. With a transdiagnostic approach, we're trying to not follow those previous assumptions. And so we're saying, well, we need to ask everyone about all kinds of symptoms, and then apply some statistical analyses to see naturally how those symptoms come together into sort of different dimensions or spectra of difficulties. So to achieve that, we ask people about 400 items in a quite a comprehensive battery. So that takes people, anywhere from 1 to 3 hours. And most of our participants are able to do that online independently. For other participants, we might do it over the phone or, over Zoom like this. And sometimes it gets done all in one go. Other times we might break it up into blocks, but we collect data on, depression symptoms, anxiety symptoms, OCD symptoms, PTSD, bipolar symptoms, substance use problems, personality difficulties, the whole sort of gamut, really. We collect data on almost all kinds of mental health difficulties, anger as well. We look at that.
So a lot of this is based on self-reporting data then?
Yeah, that's correct. And, there are strengths and limitations to that. The other way of doing it is what we call a clinical interview. So you'd meet with a clinician or a researcher, and they sort of ask you questions and probe and make a clinical judgment for themselves about whether or not you have symptoms. And there are pros and cons to each, right? So the pro of a structured interview is you get this really rich contextual information. So you don't just know about a person's symptoms, but the context around the symptoms, when they started, how long they've been going for. You can try to tease apart, is it because of the brain injury or is it because of something else? You don't get that information with a self-report. You just get a list of which symptoms a person feels they have and which ones they don't. So that's the sort of strength of a clinical interview. The con is it is incredibly time consuming. So if you imagine it's taking us 1 to 3 hours for one person to self-report these symptoms, if we were to have some sort of a structured interview to go through all of these symptoms, I have no idea how long that would take, but it would take an enormous amount of time. So we would sort of be constrained to a much smaller sample size, and we maybe have some questions about how generalizable our results are then. So asking people to self-report opens us up to having a much bigger sample size. I'm also of the view that mental health difficulties, for the most part, are something internal. It's a part of the person's internal experiences. And therefore, it just makes a lot of sense to ask folks, how are you feeling? Like, what's going on inside your head? Tell us. Self-report that. You can't always observe depression, for instance, or anxious thoughts. So I think it's appropriate to rely on self-report too.
Yeah, especially when people could, put on a mask and seem like everything's all right too.
Yeah, which we hear a lot as a coping mechanism. So we actually, not me personally, but our research center has actually done some research getting the person with a brain injury to report their mental health difficulties, and then a family member or a loved one to answer the same questions in relation to their loved one. And we often find that they are discrepant. And it's often the case that the person with a brain injury is reporting more mental health symptoms than the loved one or family member. And that's potentially because that loved one, family member, they can't see everything that's going on in their loved one's head, or as you're suggesting, the loved one, the person with a brain injury, might not give all of that information away. They might be keeping some of that to themselves.
So to get you out on here on this one, what piece of advice could you give me or people like me about recovery or going through a TBI that no one else has told me yet? Obviously, you don't know what people have told me, but what's something you think?
All right. Well, I'll try a few different things, and if you've been told it before, let me know, and I'll come up with something else.
All right.
Look, there are a few things. For me, though, I really love this mantra that there's always something that works. I think that, after a brain injury, especially in the early years, for many people, that is an incredibly overwhelming and sudden event. And you can be hit with a lot of perceived failures early on. You try things, you struggle to get back to work. You wanted to get back to work. You've tried to go back to work. It hasn't worked out for you, or you're struggling to maintain your relationships in the same way that you might have before the brain injury. And that's really disheartening. In the rehab or intervention work that I've done with people, really like to put forward this mantra that there is always something that works. You don't often stumble across the thing that works the very first time, though. And so I like to think of it as this, recovery after a brain injury for many people, if they don't immediately bounce back into what they were doing beforehand, is a process of trial and learning as opposed to trial and error. You have to just be willing to give things a crack. And if you try out enough things, you will find things that do make your life a bit better. We sort of call that relentless optimism. Sometimes the person can't bring that for themselves, but in my interactions with people, I try to bring a little bit of that relentless optimism. So that would be my tidbit, is that there is always something that works. It's a matter of trial and learn till you find those things that work for you, though. And whatever works for you doesn't necessarily, that won't be what works for another person.
Yeah, definitely. And, learning for me is also a process of adaptation, because obviously, I used to know how I do this. This is doing it the last way, the old way doesn't work. So the new way, I'll have to figure it out. It's just one of those things I've had to, I now live in a world that wasn't created for me. So I have to find my ways to be compatible with it.
It's that sort of, I don't know if you're familiar with that social model of disability, is that, yes, a person may have had something happen to them that's impacted thinking or functioning, but what can be really disabling is the society that we live in, and learning to adjust to that. So there's, emotional adjustment to a brain injury, but there's also just the practical adjustment as well. For some people, that means that they can get back to exactly what they were doing prior to their injury. For other people, it might mean finding a new normal, like what is their post-injury self going to do in life that is, personally meaningful to them. So yeah, it's a huge process adjusting, and you adjust in lots of different ways over time. Some people, that's a really quick process. Other people, that's a really long and ongoing process. And it's not necessarily linear either. You don't necessarily just have this sort of constant upwards, things are getting better, 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 better. There can be sort of steps, and sometimes you take 2 steps forward, 1 step back. It's a little bit non-linear as well.
Well, it's Jai, right? Jai.
Yes.
Great. I nailed it. Thank you, Jai, for joining me today. I appreciate it.
Yeah, thanks for reaching out on Twitter, no less. Twitter is really cool for that. So,
and talking shit too.
Add that. But yeah, I obviously really enjoy talking about this stuff. So thanks for indulging me, I guess, as well. And hopefully, I said some things that were interesting, or you learned something.
Oh, it's very interesting. I mean, hearing the medical perspective on, I obviously live this, but talking to medical professionals kind of enlightens me a little bit, and it makes me understand some of the things the way they are. So
yeah, and I think we each would have our own expertise, right? You've got the lived experience that I simply don't have. I do not fundamentally know what it's like
either, man. You don't
live
want
with a brain injury. Of course not. So I don't have that knowledge of what it feels like to have the brain injury. But I've got other knowledge, and oftentimes it's a marrying of that information that can result in good outcomes for people.
Well, thanks again, mate. I'll talk to you soon.
All right. Cheers, Eric. See you later. Have a good one.